Thank you so much, and welcome to the presentation titled Best Practices in Managing Acute Bronchitis and Acute Cough over Telemedicine. My name is Sarah Keller. I'm an Associate Professor of Infectious Diseases at the Johns Hopkins University School of Medicine, where I see patients in the hospital, in the clinic, and over telemedicine. I am one of the leaders of this antibiotic stewardship project, alongside my colleagues at NORC at the University of Chicago and Johns Hopkins University. Should you have additional questions after this webinar, please note the safety program's email address is safetyprogramfortelemedicine@norc.org. We wanted to welcome all of you to this webinar. Some of you might be coming from practices where you see some patients in person and others virtually, and some of you might be coming from practices where you see all patients virtually. Thank you for joining us today. None of the presenters have any conflicts of interest relevant to this program. The faculty and the planners or managers for the Postgraduate Institute for Medicine, Johns Hopkins University, AHRQ, and NORC also have nothing to disclose. In support of improving patient care, this activity has been planned and implemented by the Postgraduate Institute for Medicine and National Opinion Research Center. Postgraduate Institute for Medicine is jointly accredited by the ACCME, the ACPE, and the ANCC to provide continuing education for the healthcare team. For physician continuing medical education, this live activity is designated for 1 AMA PRA Category 1 credit. This activity is designated for 1 AAPA Category 1 CME credits. For continuing nursing education, the maximum number of hours awarded is 1 contact hour. This activity is designated for 1 IPCE credit. Successful completion of the CME activity, which includes participation in the evaluation component, enables a participant to earn up to 1 medical knowledge MOC points, up to 1 practice assessment MOC points in the ABIM Maintenance of Certification Program, and up to 1 MOC points in the ABP Maintenance of Certification Program. We will be using a clinical case-based format to discuss the approach to managing acute bronchitis or acute cough. By the end of this presentation, participants will be able to describe how to diagnose acute bronchitis and acute cough over telemedicine, explain why antibiotic therapy is not useful in the treatment of acute bronchitis and acute cough, describe treatment options to manage the symptoms of acute bronchitis and acute cough in adults and children, discuss strategies to communicate the time course of acute bronchitis and acute cough to patients and caregivers. We will use the 4 moments of antibiotic decision-making in telemedicine to orient ourselves as we go through today's presentation. Briefly, this framework consists of the following moments. Moment 1 is my patient an appropriate candidate for a telemedicine visit? Moment 2 is, does my patient have signs and symptoms indicating an infection that may require antibiotics? Is a diagnostic test needed? Moment 3 is, if antibiotics are indicated, what is the narrowest, safest, and shortest regimen I can prescribe? And finally, Moment 4 is, what symptomatic relief should I offer or prescribe to my patient? What should I tell my patient about the expected course and the follow-up plan? Let's review a common clinical scenario. A 54-year-old man who is a non-smoker and has no past medical history presents over telemedicine with the chief complaint of a cough that started 10 days ago. He notes that he has occasional production of white or yellow-tinged sputum. The cough is worse at night and often wakes him up. He has had no fevers or shortness of breath. Let's start with moment 1, which again is my patient an appropriate candidate for a telemedicine visit? This moment identifies patients who likely should be referred for an in-person evaluation based on the clinical presentation. Based on the initial triage note provided to you, there is no mention of the patient appearing ill with high fevers, altered mental status, difficulty breathing, or other concerning signs or symptoms. Therefore, it is reasonable for this patient to be evaluated further via telemedicine. Moment 2 asks, does my patient have signs and symptoms indicating an infection that may require antibiotics? Is a diagnostic test needed? To appropriately address these questions, you will have to rely on a patient history and physical examination. The patient's symptoms and intermittently productive cough, in combination with a lack of high fever or shortness of breath, is most consistent with acute bronchitis. However, additional history and details from a physical exam are needed to ensure the patient does not have a bacterial infection. You quickly ensure that the patient has no history of heart failure or pre-existing lung disease, and that the symptoms are not associated with a sensation of acid reflux. Earlier in his illness, the patient performed an at-home rapid test for influenza and COVID-19 that was negative. Symptoms have not worsened over the 10 days of the illness, which would be consistent with pertussis. When you're evaluating a patient via telemedicine, you can perform components of a virtual physical exam with help from the patient. Give the patient or caregiver clear instructions about what to do and where to move the camera and the light source, such as on a smartphone, and you can complete many components of a physical exam. First, ask him to check his temperature and give you the result. In this case, the patient checks and tells you that his temperature is 99.1 degrees Fahrenheit. Then, ask your patient to position himself and his camera, as well as any light sources he has available, so you can see first the inside of his nose, then the inside of his mouth, and finally, perhaps with help from a spoon or other object, the oropharynx. You may need to ask the patient to reposition himself or the camera at different points so that you have as clear a view as possible. Next, ask the patient to gently tap on his sinuses. Make sure to tell him to tap above his eyebrows, on his cheekbones, and his upper nares. Ask him to tell you how it feels. You note that his nasal mucosa are mildly erythematous with mild edema bilaterally with no nasal drainage. His oral mucosa membranes are moist and his oropharynx is not erythematous. He tells you that he has no sinus tenderness. Now you can demonstrate to the patient or caregiver where the anterior cervical, posterior cervical, and submandibular lymph nodes are and ask them to palpate these nodes. You can ask the patient or caregiver whether the lymph nodes are palpable. If they are palpable, ask if they are firm, soft, or tender. The response from the patient is that he feels no swelling or pain. Now do a virtual pulmonary exam. First, observe the patient for visible dyspnea, tripoding, or increased work of breathing. See whether he is speaking in full sentences. Note any retractions. If the patient is alone and in a private space, ask the patient if they feel comfortable removing their shirt so that you can visibly assess the chest for retractions. You can also calculate their respiratory rate. Have the patient place their hands on their shoulders. Count the rate at which you can see their shoulders raise and lower with their breaths. Then ask the patient to take a deep breath. Listen carefully for wheezing. You can also ask the patient and their family, do you hear any wheezing? It sounds like a whistle. Based on the virtual pulmonary exam, you observe no visible dyspnea. You observe no tripoding or increased work of breathing. You also know that the patient is speaking in full sentences and that there are no retractions. You calculate a respiratory rate of 15 breaths per minute, and neither you nor the patient hear any wheezing. Based on the virtual physical exam and the patient's symptoms, the patient has acute bronchitis or a chest cold. The definition of acute bronchitis is the presence of a cough with or without sputum production that lasts less than 3 weeks, generally starting in the setting of a viral upper respiratory tract infection. Antibiotic treatment of acute bronchitis is not recommended, regardless of the duration of the cough, because antibiotics do not help with resolution of cough. Of note, the term bronchitis is not applied to children. However, children commonly have lingering viral respiratory infections with a cough that can last up to 3 weeks. This cough also will not respond to antibiotics. Antibiotics do not hasten the resolution of acute bronchitis or a cough that occurs after a viral infection. This graph shows the proportion of patients with resolution of cough on the y-axis and the number of days from the initial physician visit on the x-axis. There are 3 different groups of patients with cough studied. Patients represented by the orange line did not receive an antibiotic prescription. Patients represented by the yellow line were given an antibiotic prescription and instructed to fill if they are not feeling better in 3 or 4 days. And patients represented by the green line were given an antibiotic prescription to fill immediately. Among the 3 groups, there is no difference in the timing of or proportion of patients who experienced resolution of cough. In this study, 96% of patients who were given an antibiotic prescription right away took antibiotics, but only 20% of patients who were instructed to fill the prescription if they were not feeling better took antibiotics. Additionally, 16% of patients who were not given an antibiotic prescription obtained and took antibiotics. While antibiotics do not help with cough, they can put patients at risk for adverse events that may necessitate an emergency room or clinic visit. In general, no diagnostic testing is needed for patients with acute bronchitis or an acute cough in the absence of other signs or symptoms of bacterial infection, including chest x-ray, spirometry, peak flow measurement, or biomarkers. Some might ask if the patient needs a chest x-ray. He does not have signs or symptoms of pneumonia, including fever. The remainder of his vital signs are normal, and his chest exam is normal. Therefore, a chest x-ray is unnecessary. If the patient reported fevers or shortness of breath, had abnormal vital signs, or had focal findings on his chest exam, a chest x-ray may be warranted. And no in-person evaluation is needed based on your evaluation, as no worrying signs indicating dyspnea is noted. If the patient were earlier in his illness, or if the illness were more severe, you may want to test for some other common viral infections, particularly influenza or COVID-19, via a clinic-based or at-home test for influenza or COVID-19. Reasons to test early for these might be to help you decide whether the patient may benefit from treatment, or if there are others in the household who may benefit from prophylaxis. These questions are particularly important if there is a concern for influenza or COVID-19. However, 10 days into the infection, it may not be helpful to test for other viral infections. Getting back to our patient, his symptoms are highly consistent with acute bronchitis or a chest cold based on the virtual physical exam and the patient's symptoms. Antibiotics do not help with resolution of cough, so no antibiotic treatment is recommended. An in-person evaluation is not needed since no signs indicated dyspnea is noted. Looking again at our 4 moments framework, moment 3 is, if antibiotics are indicated, what is the narrowest, safest, and shortest regimen I can prescribe? As discussed previously, antibiotics are not indicated for acute bronchitis or an acute cough. However, they are still commonly inappropriately prescribed. In one study, antibiotics were prescribed for acute bronchitis 83% of the time in virtual first or direct-to-consumer-based telemedicine, and 72% of the time in clinic-based primary care. Now we're at moment 4, which is, what symptomatic relief should I offer or prescribe to my patient? What should I tell my patient about the expected course and the follow-up plan? After informing the patient of the good news that antibiotics are not needed, it is helpful to provide recommendations for medications that might bring symptomatic relief for an acute cough if it is causing disruption in daily activities or sleep. Some adult patients may experience relief with a cough suppressants such as dextromethorphan, although limited data support the efficacy of cough suppressants. A nighttime dose of honey has been found to be as effective as dextromethorphan in reducing cough in adults and children over the age of 1 year. The expectorant guaifenesin and combination antihistamine decongestant products have been shown to have marginal effects in studies. However, if adult or teenage patients report previous positive experiences with them, they can be considered. Dextromethorphan, guaifenesin, and combination products should be avoided in children under 6 years of age and are not advised in children under 12 years of age due to serious side effects such as hypertension, cardiac arrhythmias, and even death in young children. Also, honey should not be given to children under 1 year of age given its association with infantile botulism. Other medications that can be considered for severe cough, benzonatate and codeine, require a prescription. Benzonatate suppresses the cough reflex by numbing stretch receptors in the lower respiratory tract. It should not be given in children under 10 years old due to fatalities reported with overdoses. Codeine has traditionally been used as a cough suppressant, but can cause reduced alertness and can be abused. It should not be prescribed to patients under 18 years of age due to reports of respiratory suppression and death. Beta agonist inhalers such as albuterol can improve symptoms for acute cough if the patient has described wheezing. There is no benefit to prescribing beta agonist inhalers in the absence of wheezing or a history of asthma. Patients with acute bronchitis should be told that their cough may last for at least 3 weeks and that antibiotics will not hasten resolution of the cough. For the follow-up plan, patients should be instructed to come in for an in-person appointment if they do not feel significantly better after 3 weeks. They should also be instructed to come in for an in-person appointment if they have a high fever of over 102 degrees Fahrenheit or develop a rash. They should be instructed to go to the emergency department if they develop trouble breathing, trouble swallowing, develop shortness of breath, confusion, a bad headache, or severe weakness. In summary, antibiotics are not indicated for adults with an acute bronchitis or for children with a lingering cough following a viral upper respiratory tract infection. Antibiotics do not impact the duration or magnitude of cough in either of these syndromes. Options for symptomatic treatment can be provided to patients who are experiencing cough that interferes with daily activities or sleep, although data for their efficacy are limited. Let's talk about what to do next. Sign into the program website, safetyprogramfortelemedicine.org, to review the webinar schedule for the upcoming webinars and office hours and watch recordings of past webinars. You've already reviewed this webinar, but just as a reminder, it will be available as a recording as well as a slide set with a script that you can download within 5 days following the second presentation on this topic. You can also review the one-page summaries on acute bronchitis or acute cough intended for clinicians and healthcare workers. Additionally, you can review the sample patient portal scripts for communicating with patients efficiently about acute bronchitis or acute cough. Please also consider using the patient and family educational materials. And there is a discussion guide to review with your practice about how you and your practice will manage acute bronchitis or acute cough. Please remember to complete the monthly check-in with your implementation advisor. If you are unable to submit your data or have questions, please reach out to your implementation advisor or email the safety program at safetyprogramfortelemedicine@norc.org. Thank you for joining us for our presentation today. We invite you to now ask questions.